What is the best approach to manage insulin for a 60-year-old diabetic patient on insulin glargine and Lispro the morning of elective colectomy? Hold all insulin. Give full dose of glargine and Lispro. Give 50 to 75% of glargine and hold Lispro. Switch to sliding scale insulin the night before.
Give 50 to 75% of glargine and hold Lispro. Basal insulin, glargine, is usually continued at a reduced dose, 50 to 75%, to prevent DKA. Rapid-acting insulin, Lispro, is held to avoid hypoglycemia since the patient will be NPO.
A patient with undiagnosed hypothyroidism becomes agitated, febrile, and tachycardic intraoperatively. What is the most appropriate treatment? Administer propylthiouracil, PTU, cooling, beta blockers, and steroids. Give levothyroxine and fluids. Administer dantrolene and ice. Push epinephrine and rewarm.
Administer propylthiouracil, PTU, cooling, beta blockers, and steroids. This is thyroid storm, a life-threatening hypermetabolic state. Treatment includes PTU or methimazole to block hormone production, beta blockers, esmolol, to control symptoms, cooling and steroids to support adrenal function and reduce T4-T3 conversion.
A chronic steroid-dependent patient is scheduled for laparotomy. What is an appropriate intraoperative stress dose of hydrocortisone? 10 mg IV pre-op. 100 mg IV bolus plus 100 mg over 24 hours. 25 mg IV TID. No steroids unless hypertensive.
100 mg IV bolus plus 100 mg over 24 hours. Surgical stress increases cortisol demand. A typical stress dose is 100 mg IV bolus, followed by continuous infusion or divided doses totaling 100 to 200 mg in 24 hours. Without it, the patient risks adrenal crisis.
A patient with a diagnosed pheochromocytoma is scheduled for tumor resection. What is the most appropriate induction strategy? Propofol, succinylcholine, and sevoflurane. Etomidate, high-dose fentanyl, rocuronium, and careful BP control. Ketamine and succinylcholine with lidocaine pretreatment. Dexmedetomidine and inhalational induction.
Etomidate, high-dose fentanyl, rocuronium, and careful BP control. Pheochromocytoma patients are extremely sensitive to stimulation. Induction should use cardiostable agents like etomidate and fentanyl. Avoid drugs that increase SNS tone, ketamine, sux. Carefully manage BP with alpha blockade pre-op and vasodilators intra-op.
A patient with a history of hypothyroidism presents for emergency surgery after a fall. What best describes the anesthetic concern? High risk of malignant hypothermia. High MAC requirement and difficult airway. Mixed edema coma, delayed metabolism, and cardiovascular collapse risk. Rebound thyrotoxicosis.
Myxedema coma, delayed metabolism, and cardiovascular collapse risk. Severe hypothyroidism can cause myxedema coma, especially under anesthesia. These patients have hyperventilation, bradycardia, hypothermia, and low cardiac output. They are extremely sensitive to sedatives and anesthetics. This is an endocrine emergency.